Hey, pediatric pros, let's talk tummies in trouble. Welcome to this deep dive. Our mission today, we're going to dig into a stack of source material all about pediatric gastrointestinal disorders.
That's right. And we're looking to pull out the most important nuggets, the things
Hmm.
that help you quickly spot key symptoms, really understand why hydration is so critical for these kids, and what the top nursing and caregiver priorities really are.
Yeah, think of this info as your, essential guide for assessing and caring for those little guts when things go wrong.
Hmm.
Getting a good handle on this stuff isn't just, well, helpful, it's vital. If you can spot a problem early, you can jump on it, get the right care started much faster.
Exactly. And that speed can genuinely make a huge difference in how things turn out for the child.
Okay, so let's unpack this. Where do we start? Well, the foundation for understanding any pediatric GI issue is just solid assessment. It's kind of like being a health detective, right?
Definitely. And your first big clue gathering step is taking a good history. You need to ask those really crucial questions. Okay, what's the main problem? How long has this been going on? Any weight loss?
Mm,
What about past illnesses? Anything relevant there? Recent travel?
right, the travel history, and then drilling down on the symptoms themselves.
Mm.
Like, if it's pain, you need the details. How
Yeah.
often? Where is it exactly? What makes it better or worse?
And stool patterns, oh boy, that's huge in peds. How often are they going? What does it look like? Size, consistency? Are you seeing any holding behaviors? Hiding? Doing the potty dance? Does it clog the toilet? That's a good practical
Yeah,
question.
it is. And if it's diarrhea, again, specifics, how often? How watery? Any blood or mucus?
Yeah.
Is it painful? Explosive even?
And you need to ask about cramping, bloating, get the scoop on vomiting too. How often? Is there nausea, pain, fever with it? And this is important. Do they actually feel better after they vomit?
Good point.
Yeah.
And don't forget eating habits. Have those changed? For an
Mm.
infant, are they suddenly refusing the breast or bottle?
Then you broaden out family history of GI issues. And the social side, any big stressors going on at home or school.
It's a lot of questions, but putting that whole picture together from the history is so important.
It really is. It gives you that strong starting point. Then you move on to the physical exam, really focusing in on the abdomen. The source material breaks this down into 4 key parts.
Okay, first up, inspection. Just looking. What are you looking for?
Well, how's the child acting? What position are they in? Are they lying really still? Maybe knees bent. They could make you think appendicitis. Or an infant drawing their legs up sharply.
Hmm.
And remember, the abdomen's shape changes with age. It's normally more prominent, kind of rounded in newborns, then flattens out as they get older.
And you're looking for anything abnormal during inspection too, right? Like marked distension. Maybe it even looks shiny.
Exactly. Or the opposite, a scaphoid, really flat or sunken abdomen, especially in a newborn. That's concerning.
Yeah.
Sometimes congenital issues can make parts look missing or just different.
And that practical tip about distraction, using toys, lights, letting them sit on a parent's lap, maybe even feeding during parts of the exam. That's key for kids.
Oh, absolutely. Whatever helps them relax. So after looking, you listen. That's auscultation.
Tuning into those bowel sounds.
Right. The sounds of normal peristalsis, the gut moving things along. You listen in all 4 quadrants. Note if sounds are present or absent. It's normal for them to pick up a bit after eating.
But abnormal sounds are the real clues here, like hyperactive sounds, lots of rushes,
Yeah, that could point to things like gastroenteritis, maybe lactose intolerance. And then you have the high-pitched sort of tinkling sounds. Those can be a sign of an obstruction.
and the opposite, hearing nothing.
Right. If you listen for a full 5 minutes and hear absolutely no bowel sounds, that's a red flag for paralytic ileus, where the bowel motility has just stopped.
Okay, now here's something the source really flags a critical piece of clinical judgment.
Mm.
Auscultation comes before palpation.
Yes, absolutely crucial.
Why is that order so important?
Because physically pressing on the abdomen during palpation can actually change the bowel sounds you hear. It can stimulate activity or mask things. So you have to listen first to get an accurate baseline.
Got it. Listen first. Then comes percussion, the tapping.
Right, gently tapping on the abdomen. This helps you figure out if there's distension from gas, which sounds tympanic, like a drum, or from fluid, which sounds dull. It can also give you a rough idea of liver and spleen size.
Okay, inspection, auscultation, percussion, and finally palpation, feeling the abdomen. How do you approach that, especially with a potentially anxious or uncomfortable child?
Goal number 1 is relaxation. Have them lie flat, supine, maybe knees bent. Warm hands are a must. Use gentle pressure, starting light, using your whole palm.
I like the source's suggestion about letting the child put their hand on yours during it.
Yeah, that can give them a sense of control, build a little trust. You feel all four quadrants systematically. Check for any hernias, and don't forget the perianal area. Look for fissures, fistulas, skin tags. Sometimes a gentle digital rectal exam is needed to check tone or feel for stool.
And what are you noting as you palpate?
Where any pain is located, how severe it seems. Is there muscle guarding? Is there specific localized tenderness or that involuntary guarding that really screams peritoneal irritation? Checking the flanks for pain is important too.
So we've done all this detective work history, inspection, auscultation, percussion, palpation. Why does all this detailed assessment matter so much? What's the takeaway for our listeners?
Because this is your foundation. Is how you start to figure out what's actually going on inside that little tummy. It helps you narrow down the possibilities, guides what tests you might need next, and shapes your initial care priorities. It's step one.
Okay, makes sense. So now that we know how to assess, let's dive into what we might find. The source material groups things pretty logically by the main symptom. Let's start with problems where vomiting is really prominent.
Gastroesophageal reflux, GERD, is super common, especially in babies. Simply put, it's stomach contents coming back up into the esophagus because that lower esophageal sphincter, the valve, is just immature. It doesn't seal perfectly yet.
And the symptoms aren't always just like simple spitting up, are they? It can actually make eating unpleasant, even painful for them.
Right, you might see them bring up a lot of fluid. There's also silent GERD, no obvious vomiting, but they have burning, coughing, maybe choking. These babies might struggle with weight gain because eating becomes associated with pain. They can be really irritable, cry a lot after meals, and you might see that characteristic arching or twisting during or after feeds.
And in infants, severe GERD can even cause apnea, right? Where they stop breathing for a bit.
Yes, that's a serious potential complication. In older kids, GI can look different. Maybe a chronic cough, recurrent pneumonia, chest or upper abdominal pain, disrupted sleep, a persistent sore throat.
The source specifically mentioned Sandifer syndrome. Tell us about that.
Yeah, that's that distinct arching and twisting posture some infants do during or right after feeding. It looks almost neurological, but it's actually a behavioral response to the pain and discomfort of the reflux itself. Treat the reflux, and that posturing usually stops.
Interesting. Okay, a more serious cause of vomiting, particularly in young infants, pyloric stenosis.
Right. This is where the muscle at the stomach outlet, the pylorus, thickens up and basically blocks food from getting into the small intestine. It tends to be more common in boys.
And the key symptom here, the one to really listen for in the history.
Forceful projectile vomiting. It's non-bilious, no green bile, and it happens after pretty much every single feeding, getting worse over time. Usually starts a few weeks to a few months after birth.
And sometimes you can actually see waves moving across their little belly before they vomit.
Yes, peristaltic waves. That's the stomach working really hard trying to push food through that narrowed opening. And because they can't keep anything down, this quickly leads to dehydration, poor weight gain, failure to thrive, and even metabolic alkalosis from losing all that stomach acid.
So for a child presenting with vomiting, what are the nursing and caregiver priorities?
If it's severe, they'll likely be made NPO nothing by mouth. And the absolute #1 priority is hydration. That often means starting IV fluids right away to correct dehydration.
Positioning can help too, right? Like keeping babies upright after feeds for GERD.
Definitely. Smaller, more frequent feeds can also make a difference, along with good burping. Medication administration is key PPIs for GERD, maybe something like Reglan in specific infant cases. And caregiver education is huge.
Teaching them what to watch for.
Exactly. Signs of severe dehydration, lethargy, especially if you're suspecting pyloric stenosis, making sure they understand feeding techniques, how to give meds correctly. For pyloric stenosis, it's also about preparing them for surgery, managing post-op care like slowly reintroducing feeds, and explaining that some vomiting might linger briefly due to swelling, but it shouldn't be projectile anymore.
Okay, let's shift to problems presenting mainly with abdominal pain. Appendicitis is a big one.
Huge. Inflammation of the appendix. It's one of the most common reasons for emergency surgery in kids.
And the classic story is pain starting where?
Typically starts around the umbilicus, the belly button, and then this is key. It migrates or moves down to the right lower quadrant, the RLQ.
They might also have a low-grade fever, feel nauseous, maybe vomit. Usually no diarrhea, though sometimes they might. And you mentioned that posture lying still. Knees pulled up.
Yeah, trying to minimize movement and pressure on that inflamed area. On exam, you're looking for things like rebound tenderness hurts more when you let go after pressing. Tenderness right at McBurney's point in the RLQ is classic. Pain with certain hip movements, or even pain when they jump or land hard on their heels.
And the scary sign, sudden relief of pain.
Yes. If that severe pain suddenly disappears, but the child looks really unwell, maybe toxic, that's a huge red flag for appendix rupture, surgical emergency.
Okay, next up for pain. Celiac disease.
This is different. It's an autoimmune reaction to gluten, the
Mm.
protein in wheat, barley, rye. Eating gluten triggers damage to the small intestine lining, those villi needed for nutrient absorption.
It's genetic, right? And symptoms often pop up after you introduce gluten, maybe around 6 months or later.
Exactly. Signs can include abdominal bloating, chronic diarrhea, vomiting. A really characteristic thing can be poor weight gain or weight loss. They might have skinny arms and legs, but still have a relatively normal-looking face.
Other clues?
Gas, foul-smelling, greasy stools, statorrhea, delayed growth, sometimes defects in tooth enamel. There's a skin rash, dermatitis herpetiformis, but that's maybe more common in adults. Severe cases can lead to iron deficiency, B12 deficiency, bone problems.
And the source highlighted the genetic link, much higher risk if a close family member has it.
Yeah, about 1 in 22 risk with a first-degree relative, compared to 1 in 141 generally. And it often occurs alongside other autoimmune conditions like type 1 diabetes or thyroid issues, so screening might be needed in those kids.
Then there's inflammatory bowel disease, IBD. That includes Crohn's and ulcerative colitis.
Right, these are chronic inflammatory conditions. Crohn's disease is tricky because it can affect any part of the GI tract, mouth to anus, and the inflammation goes through the entire bowel wall thickness.
So symptoms can be really varied.
Very. Abdominal pain, often RLQ again. Fever, diarrhea that can be bloody, nausea, vomiting, loss of appetite, weight loss, fatigue, anemia, delayed growth. Mouth sores are common. Can lead to complications like blockages or fistulas. It waxes and wanes, periods of flares and remission.
And ulcerative colitis, or UC.
UC typically affects just the lining of the large intestine, usually starting down low in the rectum and colon.
The key symptom there is often
Bloody diarrhea, often watery with streaks of blood. Also urgency, feeling like they have to go right now. Abdominal pain, anemia, fatigue, weight loss, loss of appetite. Can also cause growth failure and sometimes issues outside the gut like skin lesions or joint pain. Severity varies a lot.
Okay, and the last pain one mentioned is irritable bowel syndrome, IBS.
Very common.
Okay.
Affects the large intestine. The key thing here, and a major distinction from IBD, is that IBS does not involve inflammation or actual tissue changes in the bowel. It doesn't increase cancer risk.
But it's chronic and causes real symptoms.
Absolutely. Cramping, bloating, and a change in bowel habits could be diarrhea, could be constipation, sometimes alternating. The stool might look different, loose, hard, pellet-like, thin, maybe mucus in it. Urgency is common too.
And stress is a big trigger for IBS, isn't it?
Often is, yeah. And diagnosis is usually based on the history and symptom pattern rather than tests showing inflammation or damage like in IBD or celiac.
So for this whole group of conditions causing abdominal pain, appendicitis, celiac, IBD, IBS, what are the nursing and caregiver priorities?
Well, first, assessing pain accurately using the right scale for the child's age is fundamental. A 4V fluids might be needed, especially if dehydration is a concern, like in a severe celiac flare or lots of vomiting.
NPO status if you suspect appendicitis or an obstruction.
Definitely. Preparing the child and family for tests, ultrasound, CT, maybe endoscopy or colonoscopy. Medication management is huge. Explaining antibiotic regimens for ulcers, administering and teaching about steroids, immunosuppressants, or biologics for IBD. For IBS, it might be helping manage symptoms with laxatives or antidiarrheals as directed.
And diet education seems massive here.
Oh, it's critical. Strict gluten-free for celiac is lifelong. For IBD and IBS, it's often about identifying individual trigger foods. For associated constipation, increasing fiber and fluids.
And things like stress reduction for IBS and IBD.
Right.
Support groups.
Incredibly helpful. And caregivers must know the red flags. Pain moving or suddenly resolving with appendicitis, significant bleeding from either end, severe pain or vomiting suggesting obstruction or impaction, clear instructions on when to seek immediate help.
Got it. Let's move to problems where constipation is the main feature, the most common type.
Functional constipation. And this is a key insight. Most childhood constipation is this type. It's not usually caused by a serious underlying disease. Often starts with a painful poop, then the child starts holding it in to avoid the pain, and it becomes a cycle.
Symptoms we look for: infrequent stools, right? Less than twice a week.
Yeah, and they're hard, either small pebbles or sometimes really large. Pain with stooling is common. You might see in caprices that's leakage of liquid stool around a hard mass. It's not true diarrhea. And those holding behaviors, hiding, dancing, squeezing their buttocks.
And this can lead to impaction.
Yes, a large, hard stool mass stuck in the rectum or colon causes inability to stool, pain, sometimes even nausea and vomiting. On exam, you might feel that stool mass. You check the anus for fissures that might be causing pain.
Okay, much less common, but important to know about, is Hirschsprung's disease.
This is congenital born with it. A segment of the colon is missing the nerve cells needed to propel stool along. Creates a blockage, more common in boys.
And a big clue in a newborn.
Failure to pass that first meconium stool within the first 24 to 48 hours. Then it presents as chronic constipation right from birth, very infrequent stools, maybe ribbon-like or watery stools if liquid gets around the blockage. These kids often look thin but have a big, distended belly. Vomiting and poor weight gain are common too.
And on exam, the rectum might feel
Empty, because the blockage is higher up. Definitive diagnosis needs a rectal biopsy to look for those missing nerve cells.
Okay, the source highlights preterm constipation. What are the mainstays?
Polyethylene glycol, 33-fifter, like Meryl LAX, is often the go-to. It draws water into the stool, softens it, generally well tolerated. Mineral oil is an option, but taste and leakage can be issues. Lactulose is often used for infants, but can cause gas.
And stimulants like senna or bisacodyl.
Those are usually for more short-term rescue use for severe constipation or during cleanouts. A really critical point the source makes is about maintenance therapy needing to take the softener like PEG regularly every day, not just when they seem constipated, to prevent recurrence.
Right, consistency is key. So nursing and caregiver priorities for constipation.
If there's an impaction, the first step is disimpaction or a cleanout. That might involve enemas or high-dose oral meds like PEG. Then comes maintenance.
Which includes that regular medication use.
Absolutely. And behavior modifications, scheduled toilet sits, especially after meals, to take advantage of the body's natural reflex. Reward charts can help, using non-food rewards.
Diet changes too.
Yes, increasing fiber, the recommendation is often age plus 5 grams per day. Increasing fluids is vital. Sometimes eliminating cow's milk protein is tried. Keeping a stool diary helps track progress and medication effectiveness. And caregivers need to know when to call, like, if vomiting or severe pain develops with suspected impaction.
And for Hirschsprung's, the priorities are quite different.
Totally different. Preparing for surgery to remove the non-functioning bowel segment, managing post-op care, and being vigilant for enterocolitis, that serious inflammation that can happen, presenting with watery diarrhea, distension, fever. Caregivers need tons of education, maybe on pre-op enemas, definitely recognizing signs of enterocolitis or obstruction, and need for long-term follow-up.
Okay, switching gears again. Problems where diarrhea is the main event. Gastroenteritis seems ubiquitous.
Oh yeah. Acute inflammation of the stomach intestines, usually viral, sometimes bacterial. Huge cause of hospital visits for kids under 5.
Symptoms are pretty classic.
Yeah.
Watery diarrhea may be cramping, vomiting, headache, sometimes fever.
Exactly. And the key concern, the absolute top priority, is dehydration. Symptoms usually last a few days, maybe up to 10.
Let's really focus on hydration here. Why is it so critical with vomiting and diarrhea in kids? Why did they get dehydrated so quickly?
Several reasons. They have a higher metabolic rate, a larger body surface area compared to their weight, meaning proportionally higher fluid losses. Their kidneys aren't as mature at conserving water, and they just have smaller fluid reserves than adults. Vomiting stops intake, diarrhea increases output. It's a dangerous combination for them.
So what are those signs of dehydration we absolutely need to look for based on the source?
Okay, key things. Excessive thirst, a dry, sticky mouth, making very little urine or dark yellow urine, decreased or absent tears when crying. In infants, a sunken fontanel, a soft spot. Poor skin turgor, you pinch the skin and it stays tented up instead of snapping right back.
And the really severe signs.
Severe weakness, lethargy, just floppy or unresponsive, dizziness, lightheadedness, those mean urgent action is needed.
And severe dehydration requires.
Immediate IV fluid therapy. Typically an isotonic solution like normal saline given as a bolus of rapid infusion to restore volume quickly. Essentially, fluid loss concentrates the blood, fluid shifts out of tissues to compensate, and if it continues, those mechanisms fail, potentially leading to shock.
So given that high risk, what are the nursing and caregiver priorities for diarrhea?
If dehydration is significant, IV therapy is number 1. For mild to moderate dehydration, or once they can tolerate it, Oral rehydration is key. Using oral rehydration solutions, ORS, like Pedialyte, is best because they have the right balance of electrolytes and sugar.
And the source mentioned a specific technique for giving fluids.
Yeah, the gradual reintroduction. Start small, maybe just a teaspoon or tablespoon every 10-15 minutes. If they keep that down, slowly increase the amount, maybe an ounce every half hour, and so on. If they're actively vomiting, you might hold fluids briefly, then restart very slowly.
And a huge safety point, no anti-diarrheals like Imodium or Pepto-Bismol for kids, right?
Generally, no, not unless specifically directed by a provider. They can have side effects and sometimes mask a worsening condition. Other priorities. Keep lips moisturized, keep the perineal area super clean and dry to prevent skin breakdown. Continue breastfeeding if that's applicable.
What about diet, the old brat diet?
The source mentions gradually advancing the diet, starting with clear broth, saltines, then maybe bland foods like bananas, rice, applesauce, toast. But the emphasis now is often on returning to their regular diet as tolerated within 24-48 hours.
And empowering caregivers. What red flags do they need to know to bring the child back in?
Things like prolonged vomiting, unable to keep even small sips down, no urine output for maybe 8-12 hours or more, a sunken fontanel, really dry mouth or membranes, increasing lethargy, and of course hand hygiene. Absolutely critical to prevent spreading these bugs. Okay, let's touch on the liver, pancreas, gallbladder group. Neonatal jaundice, very common right after birth.
Yellow skin and eyes. Caused by the breakdown of extra red blood cells newborns have, plus an immature liver that can't process the bilirubin fast enough. Some jaundice is normal, but if it appears really early, like in the first 24 hours, it gets very high, that's concerning.
Right. Preemies are at higher risk. High levels can make the baby sleepy, feed poorly, which can make it worse. Extremely high levels risk kernicterus brain damage from bilirubin. But thankfully, that's largely preventable now with good monitoring and treatment.
A much rarer but very serious condition is biliary atresia.
Yes, congenital. The bile ducts are blocked or absent. Bile can't drain from the liver, leading to damage. Key signs: jaundice that persists or worsens after 2 weeks of age, high direct bilirubin levels.
Other signs: poor absorption of fats, dark urine, and what about the stools?
That's a critical clue. Stools become pale, gray, or even white, usually after the first month or two, because bile isn't getting into the intestine to give it color. The liver is often enlarged, too.
And cystic fibrosis, we often think respiratory, but major GI effects too.
Absolutely. It's hereditary, causes thick mucus. In the GI tract, this affects the pancreas primarily, blocking enzyme release. Leads to failure to thrive despite good appetite, chronic diarrhea with greasy, foul-smelling stools, steatorrhea. Can cause pancreatitis, CF-related diabetes later on.
And sometimes the very first sign is in a newborn.
Yes, meconium ileus, the thick meconium, blocks the intestine, causing failure to pass that first stool. Rectal prolapse can also happen.
Okay, priorities for these conditions. For jaundice.
Encourage frequent feeding to help flush bilirubin out. Monitor levels closely. Phototherapy if needed using special lights. Care involves eye protection, covering genitals, monitoring intake output. Teaching caregivers signs of worsening jaundice, sleepiness, poor feeding, and the need for follow-up is key.
Biliary atresia priorities.
Immediate care involves IV fluids, a special low-fat, high-protein diet, supplementing fat-soluble vitamins, A, D, E, K. Surgery, usually the Kasai procedure, is needed to try and establish bile drainage. Post-op care is intensive. NG tubes, INO, pain control, antibiotics, incision care, watching abdominal girth, monitoring stool color. Long-term may need PN nutrition, possibly a liver transplant. Huge amount of caregiver education needed.
And for the GI parts of cystic fibrosis.
The absolute cornerstone is giving pancreatic enzyme replacements before every meal and snack. Needs careful teaching, mixing capsule contents with acidic food like applesauce, not milk. Don't prepare ahead. Supplementing fat-soluble vitamins is also essential. Close growth monitoring, maybe a G-tube for extra calories. Emphasizing that good nutrition directly impacts lung health is vital. Education covers meds, diet, growth, immunization, support systems.
We're covering so much ground. A few other notable conditions the source mentions. Intestinal obstruction as a category.
Right, causing vomiting, pain, distension. And that critical point again. Bilious vomiting, green vomit in an infant is a surgical emergency until proven otherwise. Means a blockage below where bile enters.
Specific types include volulus,
Twisting of the intestine. Causes sudden severe pain. Infant might draw legs up. Bilious vomit. Needs immediate surgery.
intussusception,
Telescoping of the bowel. Causes sudden intense crying spells that come and go. bilious vomit often. Later, you might see that classic currant jelly stool, blood and mucus mixed, and other congenital blockages like atresia or stenosis presenting at birth with vomiting, distension, maybe pneumoconium, and NEC necrotizing enterocolitis, mainly in preemies, inflammation and death of bowel tissue, causing distension, bloody stools, apnea, instability. Devastating.
Priorities for any suspected obstruction.
Immediate NPO, IV fluids, usually an NG tube to decompress the bowel, prepare for tests, likely surgery, pain management, close post-op monitoring, caregiver education on recognizing signs, especially bilious vomiting, and the need for immediate care. For intussusception, sometimes non-surgical reduction with an enema works. For NEC, risk of long-term short bowel syndrome needing PN or tube feeds. The source also connects obesity in older kids and teens to non-alcoholic fatty liver disease, NAFLD.
Right. BMI over 95th percentile linked to fat buildup in the liver, not from alcohol. Often silent, maybe fatigue or RUQ discomfort.
And the key intervention.
Lifestyle. Diet, activity, reducing sedentary time. Structured programs, family involvement support, that's the focus. Meds or surgery are options much later for severe cases, but lifestyle is primary. Caregiver education on risks, healthy habits, non-food rewards.
And finally, hepatitis, liver inflammation, often viral, A, B, C.
A is a fecal-oral spread. B and C are bloodborne, sexual, mother-to-baby. Symptoms can be vague, feeling unwell, poor appetite, fever, classic jaundice, RUQ, pain, dark urine, light stools.
Priorities. Hand hygiene, especially for Hep A safe needle practices. Rest, balanced diet for the child. Antivirals available for Hep C, and vaccination is huge.
Yes, Hep B vaccine has dramatically cut rates. Hep B series is standard for infants, plus catch-up if needed. Important for family, too. Testing moms for Hep B is routine.
Wow, okay, that was a deep dive. So let's bring it back to the listener. Why does knowing all this stuff matter in their daily practice?
Well, it helps you be more perceptive, right? To catch those subtle signs we talked about, to understand why certain tests or treatments are being done, and to give really good, supportive education to families dealing with these often scary conditions.
Absolutely. Recognizing things early, whether it's just constipation or something like biliary atresia, makes such a difference in getting the right care started quickly and effectively.
It really does. And just thinking about how varied these GI problems are, sometimes it's obvious, like projectile vomiting, but sometimes it's just fussiness, or poor eating, or even skin changes. What does that huge range tell us about the power of really careful, holistic observation in pediatric care? How can you, listening now, work on sharpening those observation skills even further?
It really highlights that you have to look at the whole child, connect the dots, and not just focus on one single symptom in isolation.
So true. Okay, so we've covered key assessment points, walked through a whole range of GI disorders, from the common to the complex, really hammered home the importance of hydration, and talked about essential nursing and caregiver priorities throughout.
Hopefully, this gives everyone a really solid foundation for understanding and managing these challenging conditions in kids.
Keep things moving. See you in the next one.